Okay, well, thanks for coming back. In this presentation, now we're going to talk about antepartum care or preterm care. So usually when a woman finds out she's pregnant, she's had some presumptive signs. So she's starting to experience symptoms that might indicate she's pregnant. Then she goes to a healthcare provider, and there might be signs to the healthcare provider that can indicate that she might be pregnant. And then finally, we have our positive signs of pregnancy. So we're going to talk about what we call the 3 Ps, which is the presumptive signs of pregnancy, some of the probable signs of pregnancy, and then we're going to talk about the positive signs of pregnancy. But before I get started, I want to talk about prenatal care because it's really a good opportunity for education for the mom, and also a good opportunity to provide anticipatory guidance related to the pregnancy. So the whole goal of prenatal care is to make sure that we have a healthy mom and a healthy baby. We do that by identifying risk factors, by looking for any signs of complications, and we also provide education to the mom so she knows what to look for and what's not normal. Okay, so as I said, we're going to talk first and talk about the 3 Ps of pregnancy. So the first P we're going to talk about is the presumptive signs of pregnancy. Now, these are the subjective symptoms. So when we talk about presumptive signs of pregnancy, we're talking about things that can indicate that she might be pregnant, but they don't necessarily mean that they're definitely pregnant. So when we talk about presumptive signs, again, these are just signs that the mother reports. It's helpful if we talk about the difference between a sign and a symptom. So when we talk about a symptom, that's very subjective. So that's what we're talking about here. It's something that's reported by the patient. And when we talk about a sign versus a symptom, a sign is something that's more objective. It's something that's going to be witnessed by an observer. So these presumptive signs of pregnancy are those subjective symptoms that women report. And many women who present for assessment of pregnancy come because they're starting to have these symptoms that are pretty consistent with pregnancy. So the thing to know about presumptive signs is they can be caused by other conditions other than pregnancy. So in that way, they're the least reliable indicators of pregnancy. So what are some of these presumptive signs? You missed a period, which again, that can be caused by something else. It can be caused by stress. It can be caused by hormone changes. It can be caused by eating disorders. There's other reasons that could cause a woman to miss a period. We know nausea and vomiting. I'm sure many of us have experienced nausea and vomiting and have not been pregnant. Fatigue. I'm pretty sure that counts for most of you right now while you're in nursing school, so it doesn't necessarily mean pregnancy. We know urinary frequency can be a sign of pregnancy, but could also be a sign of something else, such as a UTI. Breast and skin changes, and even vaginal and cervical color changes can also happen, especially with hormonal changes. And even fetal movements sometimes might be reported when it's actually just gas. So again, these presumptive signs are things that the woman's feeling that may be an indicator that she's pregnant, but it's the most unreliable indicator of pregnancy. Then we talk about probable signs. So when we talk about probable signs, we're talking about objective signs. So these are the ones that are perceived by the provider as objective signs, and they're likely to be a result of pregnancy. They're more indicative of pregnancy than the presumptive signs, but it's still only probable because, again, some of the other things can cause these symptoms. Abdominal enlargement, that could be a sign of pregnancy. I don't know about you, but I experienced some abdominal enlargement over the holidays, so I'm definitely not pregnant. just gained a bit of weight. So also there might even be some cervical changes. And so remember we talked about the softening of the cervix, which is Goodell's sign. Sometimes that can occur without pregnancy and be related to other hormonal issues. Even some of the uterine changes, we're going to talk about some of these, but one of the ones we're going to talk about is Hegar's sign and Ballottement. Sometimes the provider might feel these signs, but again, it could be caused by something other than pregnancy. And oftentimes not oftentimes, but there are times when you can have a positive pregnancy test and actually not be pregnant. So again, these objective signs are stronger indicators of pregnancy than the presumptive indications, but we can't diagnose pregnancy based on these findings alone because we could have other causes. So that brings us to the positive indicators of pregnancy. So when we talk about positive signs of pregnancy, these are the things that are only caused by pregnancy, nothing else. So if we can actually hear the fetal heart rate and it's not the same as the maternal heart rate, we're definitely positively pregnant. If if the examiner can actually feel the baby kick, move in utero, then definitely, unless there's an alien there, she is definitely pregnant. And if we put on an ultrasound and we can see a gestational sac and even a fetus, again, that's only caused by pregnancy. So those are your positive indicators. So one of the things that you have in your little module, again, there's actually a practice for the 3 Ps. So it will ask you, you'll give you signs and symptoms, and you'll just put them under the probable, the presumptive, or the positive. So that's just a little activity that you can practice those. So a couple things I talked about that I wanted to explain what they are. One of the things I said was Hegar sign. Hegar sign is something that can happen with pregnancy. Usually around 6 to 8 weeks of pregnancy, the lower uterine segment, we call that the isthmus, the lower part of the uterus, becomes so soft that a provider can actually compress it to the thinness of the paper. Very, very thin. And that's called Hegar sign. Why anyone would want to do this, I don't know. I'm not sure who Hegar is, but why was he pressing down on uteruses in the first place? But anyway, that is a sign that can be associated with pregnancy, but it's definitely not one of those positive signs, but it can be associated with pregnancy. This is another crazy one. We call this ballottement. And I always get I always kind of get a giggle out of this because, again, why did someone ever do this in the first place to discover that it can be associated with pregnancy? So basically with ballottement, if the cervix is tapped, so the provider taps the cervix, if there's a fetus in there, the fetus actually will float upward in the amniotic fluid, and then it comes down, and the examiner can actually feel the rebound of the fetus coming down, so they can feel that with their finger. Again, why is someone going around tapping a cervix is beyond beyond my knowledge, but basically that's what we call ballottement, is when that baby can actually rise and then fall back into you feel that rebound with the finger. So I just wanted to go over those. So let's talk about antepartum assessment and prenatal care. So ideally, we really do encourage all women to have what's called a preconception visit. So this is a visit with their healthcare provider before they get pregnant. And this is a great thing to do because this is a way to determine, getting your body into the optimal shape for pregnancy. So for example, one thing that we really encourage is folic acid during pregnancy. That helps prevent neural tube defects. So folic acid is very critical. Folic acid is especially critical in the first 6 weeks of pregnant. And a lot of times women don't even know they're pregnant during those first 6 weeks. So this way they can start taking a prenatal vitamin before they're even pregnant so they can get the benefits of the folic acid. Some women are rubella non-immune, so they're not immune to rubella. In those cases, rubella can cause miscarriage. It can cause other problems with the pregnancy if they acquire it during pregnancy. So if a woman is not immune to rubella, a preconception visit is a good time to find that out, because we can actually immunize her. We can give her the rubella vaccine so that she'll be rubella immune during pregnancy. The thing about rubella is you can't give it during pregnancy. It's a live virus. You can't give that vaccination during pregnancy. And so again, if they have preconception care, we'll go ahead and we'll get that vaccination done if she's not already rubella immune. We then have to tell them to wait 4 weeks before getting pregnant because it is a live vaccine. So they do need to delay pregnancy for about 4 weeks, but it's better than having acquiring rubella during pregnancy. So ideally, if they're diabetic, if they're overweight, this is a good time to get them in the best shape possible, even before conceiving. So if they haven't had preconception visits, or they have and they become pregnant, the next thing they're going to do is establish prenatal care. Okay, many of the prenatal visit, the first prenatal visit, is really the time that they're healthcare provider is going to kind of get to know them, and their healthcare provider might be a doctor, or it could be a midwife, and at this point they're establishing rapport. They're performing an assessment of the physiological and the psychosocial needs of the woman, and they're doing a thorough history and physical. So again, they're confirming the pregnancy. Then they're going to do some critical screening, some assessments, some laboratory tests, start with patient education, and start having some care planning considerations as well. Now, one of the first things that we have to do when a woman presents to pregnancy is we want to determine her due date. And another term for that is the estimated date of delivery, or the estimated date of confinement, which is basically, okay, so with the due date, we can actually estimate that based on the first day of their last menstrual period. So the average duration of pregnancy begins on the first day of the last menstrual period, and so it tends to be 40 weeks or 280 days, okay? But we don't start it at the date of conception. We start it on the first day of the last menstrual period. So we want to know, when was your last menstrual period? What was the first day of your last menstrual period? Based on that, we can actually calculate the estimated due date following something that's called Naegeli's rule. So Naegeli's rule is actually pretty simple. All you do is get the first day of her last menstrual period, you subtract 3 months from that date, and you add 7 days. And that's all you have to do. So just with subtracting 3 months, adding 7 days, that will give you the woman's due date. And of course, we would always confirm that with a sonogram as well, if needed, but not, usually it's not needed. It's usually pretty spot on, unless a woman's had a history of very irregular menstrual periods. So let's look at that again. So here's Naegeli's rule. So we say, what was the first day of your last period? And she tells us November 21st. So now we're going to subtract 3 months. So in this case, November minus 3 months is August. So November 21st, August 21st. And then we're going to add 7 days. And that gives us our date of August 28th, which of course we know will be the following year. So her estimated date of birth is August 28th. So pretty easy, right? Just subtract 3 months, add 7 days. Okay, so that's Naegeli's rule. And you can expect on your test that you might have to calculate a due date based on the woman's last menstrual period. So you also have a practice activity in your module. You can practice determining due dates for women. Another way to determine the due date is the use of a gestational wheel. You don't see these used much anymore because we have computer systems that we can quickly calculate due dates. I mean, we're much more able to do that. Now, when I started nursing, OB nursing, which was 25 years ago, like, so, we still have dinosaurs, things like that. We use these gestational wheels a lot. And basically, it's a wheel on top of a wheel. And they have little arrows, and you point one arrow to the first day of the woman's last period, and then you find another arrow that's going to be at the site of the due date. So it's pretty easy. You just twist it. The other good thing about this is, let's say we have a woman and her due date was August, her last menstrual period was November, and she comes in and sees us in October. We can determine by this wheel how many weeks her gestation is. So based on her last day of her menstrual period, it's now August 15th, we can quickly see how many weeks pregnant she is. That was a bad sample because I said her last period was November. So let's say she came in January. We could determine how far along she was. Okay, the other thing that we need to do once we determine due date is we have to have notation of pregnancy history. So some of the components of the obstetrical history is determine a woman's gravida parastatus. So sometimes this can be a little bit confusing, and again, I do have a sample activity for you that you can do in your modules to get a little bit better. So one of the things we talk about is gravida. When we talk about gravida, we're determining the number of pregnancies, whether it ended in a preterm birth, whether it ended in a term pregnancy. It's the number of pregnancies that the woman has had, and that includes the current pregnancy. So how many times have you been pregnant, including the current pregnancy? And that gives us our gravida. Okay. Para is a little bit different. When we talk about para, we're talking about the number of births that were completed at or after 20 weeks gestation, regardless of outcome. So if we had a fetal loss or anything like that, we still count it. Now, this is a little bit confusing. So if a woman's had a miscarriage prior to 20 weeks, we can't count this as a para because it occurred before 20 weeks. So it has to be a pregnancy that was completed at or after 20 weeks gestation before we can call it a para. Now, it's important to remember that para is made on the number of pregnancy, not the number of fetuses. So if she had a baby born at, say, 36 weeks gestation, which is past 20 weeks, even though it was twins, she still had one pregnancy. So we would say gravida 1, para 1 with those twins. Okay, and this is after they've given birth. So a lot of times we have women who are gravida 1, para 0 because they haven't given birth yet. So any pregnancy that has twins, triplets, so forth, still counts as one pregnancy and one birth. Okay, so para is just the number of births completed at or after 20 weeks gestation. And then we take these numbers and we do another history where we determine TPAL, which stands for how many term infants have you had? How many preterm, how many term pregnancies have you had? Again, we're not going by number of, we're not going by multifetal pregnancies. We're just saying number of pregnancies. So how many pregnancies ended up with a term gestation? How many pregnancies were preterm? And for the purpose of this course, we're going to consider 37 weeks and above term labor. Okay, preterm labor is considered less than 37 weeks, but greater than 20 weeks, because we know anything less than 20 weeks can be a miscarriage, and we're going to talk about that in just a little bit. And then post-term pregnancies are generally 42 weeks and above. Hopefully not too much above. That's a long time to be pregnant. So term pregnancies greater than 37 weeks, preterm pregnancies less than 37 weeks. So an abortion is the medical term for any pregnancy that ended prior to 20 weeks. And I know some people have a negative connotation with abortion, but that is indeed the medical term for all pregnancies that end prior to 20 weeks gestation. So that does include medically induced abortion, but it also includes spontaneous miscarriages. Now, again, it is the medical term for all pregnancies that end prior to 20 weeks, but you want to be very careful with that. I mean, as healthcare providers, we understand that's the medical term, but some other people may not necessarily understand that. So if it's necessary to say miscarriage or anything, that's appropriate too. But abortion is the medical term for all pregnancies that end prior to 20 weeks. So we know when we go back to our gravida para, then an abortion is ending prior to 20 weeks, so it's never going to count as a para, if that makes sense. And then living children. So now we're actually accounting for the number of children. So all the other ones are just the delivery, the pregnancy. Doesn't matter how many babies are in there. But once they're born, they count separately. So living stands for the number of currently living children to whom the woman has given birth. So let's say I've had a woman, she came in, she was pregnant. So she's a gravida 1, para 0. She ended up delivering twins at 37 weeks gestation. So she has she's a gravida 1, para 1, but then she has 2 living children because the twins, now that they're out, count as 2 separate people, if that makes sense. So that's kind of how we do it. And I do have some practice ones to go over with you. So for example, let's look at Mrs. G. She's had 1 child who was born at 30 weeks gestation. And so we can go ahead and say, okay, we know she's been pregnant once, so G1, and we know that it was a term pregnancy, so we can do G1, T1, right? And then she had a second pregnancy, and so she became pregnant for a second time. So we know now that she's had at least 2 pregnancies, so she's a gravida 2. But this time it ended in miscarriage at 14 weeks. So we would still be, we count our first term baby. We've had no preterm babies. We've had 1 abortion, okay? Now she's currently pregnant for a 3rd time. So automatically we know she's a gravida 3. This is her 3rd pregnancy. So how would we record this? Well, we know she's had 1 child who was born at 38 weeks gestation. So we know she's a gravida 3, para 1, because that's a pregnancy that went past 20 weeks. Okay, we also have term 1 because that baby was born after 37 weeks gestation. We have preterm 0. We've had no preterm babies. We have had 1 abortion. And now we have 1 living child as far as we know, which is that 38-week gestation. And again, she's pregnant for the 3rd time, so we don't know what her TPAL will be until she has this baby, what it will change to. Okay, so just gravida 3, para 1, T1, preterm 0, abortion 1, living 1. Now this one's going to be a little bit more complicated. Now we have Mrs. P, and she's pregnant for the 4th time. So automatically we know if she's pregnant for her 4th time, then she's had 4 pregnancies. So she's definitely a gravida 4. Okay, so at home, she has a child who was born at full term. So we can say that's term 1. Right? We've had 1 term delivery. Her 2nd pregnancy ended at 9 weeks. So that's going to fall under abortion. So we have term 1, abortion 1, right? She then gave birth to twins at 35 weeks. So we count this as 1 pregnancy, even though it's twins, but because it was 35 weeks, we put that as a preterm delivery, right? So after delivery, she has a term and she has 2 preterm babies. So her living children are actually 3. So she's going to be a gravida 4, 4 pregnancies. She's had 2 pregnancies, her term and her preterm pregnancy that went past 20 weeks. So we can say she's a P2. And then when we do her TPAL, we've had 1 term, 1 preterm, 1 abortion, and currently we have 3 living children because we had 2 preterm babies that are alive and 1 term baby that's alive. So I hope that makes sense. Again, there's lots of practice opportunities in that module where you can get a little bit more comfortable with that. And again, feel free if something kind of comes back later and you're like, what was she talking about? Please always feel free to reach out to me. I'm so happy to talk to you all, and I'm so happy to have any conversations that can enhance your learning. So please feel free to reach out to me if later on that doesn't make as much sense anymore. So now that we've got a pregnancy history from her, we're also going to do. So we want to know, what was the weight of your last babies? Are they big babies? Do they tend to be small babies? What was the length of gestation? Do they tend to have preterm deliveries? That's important to know because she's a higher risk of preterm delivery with this pregnancy. Or have all of her pregnancies been term? Has she suffered miscarriages before? We want to know about her labor experiences when she delivered. Were there any complications? What type of delivery? Was it a vaginal delivery or was it cesarean delivery? Did they have any pain management like anesthesia, like an epidural? Did they have any difficulties with anesthesia if they had that during pregnancy? Or even in the past, have they ever had problems with anesthesia during surgeries? We want to know maternal complications such as hypertension. Did they have hypertension with their last pregnancy? If so, they might be a higher risk to have an hypertension this pregnancy. Do they have diabetes, or did they have gestational diabetes with one of their pregnancy, or did they have any bleeding issues during pregnancy? These are all the things we want to know. Were there any infant complications? Did you breastfeed in the past? How do you plan to feed your baby with this pregnancy? Or any special concerns that they have? This is the time we want to kind of talk about that and get an idea. Of course, as with an obstetrical history, it's also important to know their medical surgical history, and especially things that can impact pregnancy. So any chronic illnesses such as asthma, heart disease, hypertension, diabetes. With asthma, we are concerned that the women can have asthma attacks, which is obviously going to affect the oxygen that gets to her baby. We want them to know that their asthma medications are safe to take during pregnancy, and we want them to avoid having an asthma attack. If they have heart disease, as you can imagine, even a normal healthy woman is going to have increased cardiac output and have increased cardiac demands on them. So you can imagine if you have a history of heart disease, that's going to be a lot of extra demands on the body. So we need to know about that. If they have a history of hypertension, we know that pregnancy can alter that chronic hypertension, and sometimes lead to something that's called preeclampsia, which we'll talk about later. Do they have diabetes? Because that's going to factor into how their pregnancy is managed. Any previous illnesses or surgical procedures and injuries. Sometimes that's important. You know, maybe they haven't had a C-section before, but maybe they've had another type of uterine incision that we might need to know about. Or we might need to know about surgical procedures where maybe they didn't tolerate anything well. We want to know about any previous infections. Do they know they have HIV, hepatitis B? Have they had a history of anemia in the past, because they're likely to have anemia during pregnancy? What is their caffeine and alcohol and tobacco use? We want to talk about their prescription and over-the-counter medications. Not all medications or herbal remedies are safe for pregnancy, so we want to make sure we know what that is, that women check with their doctor before taking any new medication, and make sure that we take things that are safe for pregnancy. We want to know about their general nutrition, any history of eating disorders, any drug sensitivities or allergies, and also psychosocial history, because there are mood disorders that can also accompany pregnancy. I mean, I'm sure you've all heard of postpartum depression. So that's important to know, because a lot of women, if they've had a history of depression, are going to be more likely to have postpartum depression. Not all antidepressants are good for pregnancy, so we might have to put a different type of medication during pregnancy. So these are all important things. We also do the physical examination, so we get vital signs. So we want that baseline blood pressure, pulse, respirations, and temperature, because we're going to be referring back to that as pregnancy. So we expect, again, the pulse is going to increase from about 15 to 20 beats per minute. We know their respiration is probably going to increase by about 2 breaths, and we know that their blood pressure should be staying the same. We're going to also check for any of that non-dependent edema. We're going to look and do a complete exam of the musculoskeletal system, neurological, integumentary, endocrine, gastrointestinal, urinary, and reproductive system. So usually the woman's going to also have a speculum exam and a bimanual examination. They're going to take pelvic measurements to make sure that, you know, the pelvis is adequate for a vaginal delivery. This is the very first prenatal visit. Now, we're also going to collect some laboratory data. One of the most important things we do is to determine the blood type and the Rh factor. And why is this important? Well, if mom has an Rh negative blood type and has an Rh positive fetus, her body can actually produce antibodies to that fetus and can attack the next pregnancy. So any mom who's Rh negative, we go ahead and we administer a medication called RhoGAM at 28 weeks. This medication will help prevent the mom getting antibodies, okay? So if a mom is Rh negative, she's going to get a shot of RhoGAM. Now, if her baby comes out and is Rh negative as well, we don't have to do anything because she didn't develop antibodies to the Rh negative fetus. But if the fetus comes out and it's Rh positive, and we test them after their delivery by using cord blood, if they're Rh positive, then it's likely that this mom has made antibodies. So if she were to be pregnant again with an Rh positive baby, her body would attack that pregnancy. So if the baby is Rh positive, we give her another shot of RhoGAM after delivery. If baby is Rh negative, we don't have to do anything because we don't have to worry about antibodies being formed. So that's why it's so important to know what their Rh factor. So are they A positive or are they A negative? We also do a complete blood count. Again, we do urinalysis as well. And as I mentioned, this is pretty common afterwards. We do urinalysis if a woman reports to a hospital for any reason. We always dip their urine, and it's always done in the office as well. We're going to screen for sexually transmitted diseases, especially gonorrhea and chlamydia. Syphilis is something we also look at, as well as HIV, hepatitis B, and herpes simplex virus. So all of these can actually cross the placenta and affect the baby. So if there's any gonorrhea or chlamydia or syphilis, we want to be able to treat those. HIV and syphilis is actually screened twice during pregnancy. It's screened during the first time they have prenatal care, and then next it's going to be done in the 3rd trimester. So we do that twice. We also, at the first visit, will do, as I said, with the speculum exam, we'll do a pap smear. And then women are also offered an opportunity to have what's called a multiple marker screen. And I actually don't see these much anymore because they've been replaced with DNA testing. But basically what the multiple marker screen was, is it was actually you would draw maternal serum and you would determine based on the serum results the risk factors for having either a chromosomal anomaly or a what am I trying to say? A neurological issue with the baby. So it's kind of a predictor test that, you know, says like, yeah, this baby's high risk for spina bifida or this baby's high risk for Down syndrome. Now it's just a predictor test. So these weren't very reliable. So it just kind of tells you have an increased risk. But based on that, women could choose to have more invasive tests, and we'll talk about those later, like an amniocentesis or chorionic villi sampling, or they could choose not to go further. So this is always offered as an optional thing. When I was pregnant with my son, who's 20 years old right now, by the way, he's a third-year Concordia student. When I had my son, they offered the multiple marker screening. I decided to decline it because I knew it wouldn't affect the outcome of my pregnancy. I thought it would just create anxiety. And so I just decided not to have it. And a lot of women just decide not to have it. But as I said, it's not really reliable. And since then, it's been replaced with the serum testing again, but now it's actually looking at the DNA. So not only is it more reliable, but at the same time, they can even determine the sex of the baby from it. So you know if you're carrying a boy or a girl just from that just from that DNA test. Torch infections. I wanted to talk about torch infections because these are infections that can actually mom can have, and it can actually spread. It can actually cross the placenta and affect the baby. So toxoplasmosis is one of them. With toxoplasmosis, it can be found in uncooked meat, but it can also be found in cat feces. And so usually if a mom's pregnant, we tell her not to change the litter box when she's pregnant because of the risk of acquiring toxoplasmosis. O stands for other, which is usually your hepatitis, your syphilis, your HIV. So this all crosses the placenta. The rubella, we talked about that. So that's the only one you can actually get immunized for. That's kind of cool. And of course, hepatitis B. Cytomegalovirus, that can also cause problems during pregnancy if it's acquired, and also herpes simplex virus. So these are things that are also tested for. The one thing I don't see tested for very much anymore is the toxoplasmosis and the cytomegalovirus, because most of us have been exposed at some time during our life, but they will definitely do the other ones, the hepatitis, the syphilis, the HIV, the HSV, and the rubella. So those are your torch infections. Now, we're also going to talk about prenatal visits and when they occur. So we want people to establish prenatal care as soon as they find out they're pregnant. So hopefully in that first trimester. After that, from the time that they've conceived until the time they reach 28 weeks gestation, we want to see them every 4 weeks. So again, just 4 weeks where we do brief assessments, make sure everything's going okay. Once a woman passes 28 weeks, between the time she's 29 weeks and 36 weeks, we usually want to see her every other week, so every 2 weeks. And then once she hits 37 weeks, we usually want them to come in weekly until they actually give birth. Okay, so those are kind of the assessments of that. During these visits, again, vital signs and weight, we're going to track the weight and make sure that they're gaining weight in an appropriate pattern. As I said, we always dip their urine. Women who do not have pre-existing diabetes can develop diabetes during pregnancy, and we call that gestational diabetes, okay? So it's diabetes that's only recognized during pregnancy. So obviously, if they were already diabetic, we don't need to do this test. But otherwise, we do a glucose screening on women, and I'm going to talk more about this more in detail about later on in the course. But around 24 to 28 weeks gestation, we have the woman do what's called a glucose screening. So we have her drink this sugary type of water, and then we do monitor her blood sugar. And from that, if we have like elevated blood sugars, we can go ahead and determine that she has gestational diabetes. And we're going to talk more about that later. Isoimmunization. So isoimmunization, once again, it refers to an antibody test. So we do isoimmunization, and antibody tests can be repeated if a mother's Rh negative. So all mothers who are Rh negative, as I already mentioned, will receive RhoGAM, which is this medication that helps to protect them prophylactically. So 28 weeks, all women who are Rh negative are going to get it. And then whether or not they get a second dose is going to depend on whether or not they delivered an Rh positive or an Rh negative baby. We're going to do fundal height measurements. So again, it's a very inexpensive and it's a very non-invasive method for evaluating fetal growth. And if we saw some discrepancies, like maybe this baby's measuring 36 centimeters, but we anticipated only being 32 weeks, we would follow that up with an ultrasound. Anytime we have discrepancies, we would do an ultrasound. Leopold's maneuvers, we're going to talk more about that next week, but it's just a series of manipulations we can do with our hands to help determine fetal position. And we'll talk about that more next week. Usually around 16 weeks or so, usually you'll start to be able to hear fetal heart rate. And so we'll also start tracking that. Normal fetal heart rate should be between 110 and 160 beats per minute. And we're also going to have the woman observe herself for fetal activity. So usually around 28 weeks, we tell women to do what's called kick counts and to measure that they're having fetal movement throughout the day. I usually say do it at the same time when the baby's most active. So for example, when I was pregnant, as I worked during the day, I think it would just rock the baby to sleep. So I didn't feel a lot of fetal movement during the day. But at nighttime, when I lay down, all of a sudden, you know, he rock and rolled in the uterus, and that's when I would do my kick count. But vigorous fetal movement is very essential. That's a reassuring sign of fetal well-being. If you're not feeling fetal movement and it's been a while, that we would want you to come to the hospital to be evaluated. Now, bear in mind, babies do go through sleep cycles, but generally they're pretty short. They're about 20 to 40 minutes. So if it's been a couple hours of not feeling the baby move, we would want you to come to the hospital. Another test that we do as a woman approaches the end of pregnancy is we test for something that's called group B strep. And again, all of this is in your little mini module, your little minitation for perinatal infections. But group B strep is normal flora. Like, it doesn't hurt us at all, but it can be catastrophic to babies. Because it's normal flora, we don't treat it until the woman's actually in labor. And when she's in labor, we're going to be giving her antibiotics. The gold standard's penicillin if they don't have an allergy. And we're going to give her antibiotics throughout labor to prevent the baby getting group B strep. So it basically at 35 to 37 weeks, they do a little swab of the rectum and the vagina. And the presence of group B strep is again, an indication for prophylactic treatment with IV antibiotics during labor and delivery. So again, very normal to us. We don't treat it before because it's normal flora. It will come back. We just treat the woman in labor because we're actually treating the baby. And this is just a little cheat sheet for your RhoGAM here. So again, you might hear the term isoimmunization. You might hear the term Rh sensitization. You might hear Rh incompatibility. Those are all basically the same thing. And it's a condition that happens when a woman's blood protein is going to be incompatible with the fetus that causes her immune system to react and starts to destroy the fetal red blood cells. And so again, we do it at 8 weeks for all negative women. Even though it's not going to affect the first pregnancy, some women can have had a prior pregnancy and a miscarriage and never even know that they were pregnant. So any mom who's Rh negative, we always give them RhoGAM at 28 weeks. And as I said before, after they have the baby, we determine if the baby's Rh negative or positive. If the baby's negative, we don't have to do anything. If the baby's positive, we'll give another dose of RhoGAM. Here's measuring the uterus. So we talked about that. So again, that enlarging uterus helps provide information regarding fetal growth. Again, we don't do it prior to 16 weeks, and we usually don't do it after 36 weeks because it's no longer accurate. But you can see the provider just took a measuring tape from the symphysis pubis. They go over the abdominal curve right to the top of the uterus, which is the fundus. They look at it in centimeters, and then again, it should match what the baby's age is in weeks. This is another just fun little PowerPoint that just goes over some, it's hard to read now, but if you print out the slide, you can print it out bigger. But again, it just talks about the 3 Ps that we talked about earlier, some of the tests that we do. It reviews Nagelli's rule and talks about our prenatal visits. So just a quick little memory aid, I guess. It's also important to talk about prenatal education, because the prenatal visit is really the opportunity for education. And I talked about anticipatory guidance as well related to pregnancy. So women need to know what's back. So topics that we address include health promotion during pregnancy, recognition of complications of pregnancy or common discomforts of pregnancies and how to deal with them. Again, nutrition and weight gain, necessary lifestyle changes, recognition of possible complications of pregnancy, as well as preparation for labor and birth, which might include, prenatal classes. Who do you want for your labor support person? What are your pain management plans? Do you have a birth plan? Things like that. And then also postpartum decision making might include contraception after delivery, how they want to feed their baby. Who is going to be their baby doctor? Do they have a pediatrician picked out? If it's a boy, do they want the boy to be circumcised? So those are all things to be talking about during that prenatal period. Now, as I mentioned, I did make you a cheesy little video on discomforts of pregnancy and ways to overcome those discomforts. So I do want you to be familiar with those, which is why I made a little video. But just quickly, some of the common discomforts of pregnancy: nausea and vomiting, heartburn, backache. Some women have what's called round ligament pain, which are the ligaments that attach to the uterus that kind of stretch, and as they stretch, it can cause pain. Urinary frequencies, varicose veins, constipation and hemorrhoids, leg cramps, all those fun discomforts of pregnancy. It's important that we talk about necessary lifestyle changes. So again, this is teaching about lifestyle changes to avoid adversely affecting the fetus. So that might be your prescription and your over-the-counter drugs. So we really want to advise all pregnant women to consult with their healthcare provider before taking any type of drugs. And this is important for prescription drugs and over-the-counter drugs. We tell them to avoid NSAIDs, like aspirin and ibuprofen. NSAIDs need to be avoided because they increase the risk of bleeding. And also, when prescription drugs are necessary, we really want the healthcare provider to kind of weigh the risks as opposed to the benefits. We want to talk about complementary and alternative therapies, because there are some complementary and alternative therapies that are very safe and helpful during pregnancy, but there's also some that are harmful. So it's important to talk about complementary or alternative therapies being used and making sure that we advise the woman to talk to their healthcare provider about those. Tobacco use, there's so many risks associated with the use of tobacco in the mother and how it affects the developing fetus. So again, women who use tobacco should be encouraged to stop smoking. Even secondhand smoke can increase risks to the fetus as well. So even if we have to do a nicotine, it's not ideal, but it's still better than smoking. Alcohol. So alcohol is what's called a known teratogen, which means it causes birth defects. Okay, and maternal alcohol use is one of the leading causes of intellectual disability in the United States. So alcohol can produce some developmental anomalies, such as fetal alcohol spectrum disorders. And so we really want to make sure that the woman abstains from alcohol in pregnancy, especially in that first trimester. Remember, that's when everything is initially being developed. Later on in pregnancy, some healthcare providers will say, sure, have a glass of wine occasionally, like in the third trimester. And usually that's not going to be harmful, but definitely in the first 12 weeks to avoid that. And of course, illegal drugs, cocaine, heroin, methamphetamines, these can be very harmful to the fetus and the infant. It can be very harmful during pregnancy. And so we really want women to seek help Some of these drugs are not safe to stop cold turkey. So that's why we really want people to be honest, and we can think of better ways that we can help. So for example, if you have a mom who's a heroin addict, although it's not ideal, but maybe methadone can be helpful for that, even though methadone can cause issues too, at least it doesn't cause some of the scarier issues of actually injecting a medication. We want to talk about signs of possible complications. So we talk about what are normal discomforts and what things are not normal. So it's very important we educate her about signs and symptoms of possible complications and make sure that she knows to call their healthcare provider or go to the hospital immediately if she's having any of these signs. So vaginal bleeding with or without discomfort, that's very important. That's not normal. We definitely want her to seek help. It could be due to miscarriage. It could be due to placental issues. Rupture of membranes. Anytime the woman's amniotic sac breaks or she thinks her bag of water broke, maybe she had a big gush, maybe she had a trickle of fluid, we do want them to go to the hospital because that amniotic sac is our last barrier to infection. So once that amniotic sac breaks, we can have pathogens that actually enter the uterus and can cause an infection. So we want them to come to the hospital as soon as possible. Now, some women can think their water broke, and we go ahead and we can actually test them. We have a little test that's pretty easy. It's just a little Q-tip. You put it in the vagina, you make awkward conversation for about 15 seconds, then you pull it out and you put it in a little tube and send it to the lab, and it can tell us with 99.9% accuracy whether or not it's amniotic fluid. Some women, as they get closer to term, their babies are getting bigger and they tend to kick hard, so sometimes they might just give that bladder a big kick and they spill fluid, but they're well hydrated, so it doesn't look like, doesn't smell like urine, but it's not amniotic fluid. And even though some women think that might be embarrassing, it's still better than being ruptured for days and never seeking help. I mentioned how dependent edema is normal, but non-dependent edema, like swelling of fingers, puffiness of face, or around the eyes, that's not normal. That can indicate hypertensive problems like preeclampsia, as can a continuous pounding headache that is not relieved by Tylenol. That can be another sign of preeclampsia, as can visual disturbances. If they're having spots in front of their eyes, they're having blurry vision, that can also be a sign of preeclampsia. And we're going to talk about preeclampsia later on. Women should not have a persistent or severe abdominal pain at any time. That could indicate maybe an ectopic pregnancy. It can also indicate a placenta that starts to prematurely separate from the uterine wall. It can be a sign of preeclampsia. So any of these things we want them to report. And sometimes everything's fine, but in case, we want them to report it. Chills or fever, which can indicate an infection. And as I mentioned, infection can trigger preterm labor. We're seeing that a lot with COVID patients, that they're going into preterm labor and having preterm deliveries. Painful urination, that could be a UTI, which is also an infection. Persistent vomiting, that's the one I was telling you about, can be called hyperemesis gravidarum, which we might have to treat. Anytime you have decreased fetal movements or lack of fetal movements, that can indicate fetal compromise or death. Again, a baby who moves well in utero is a pretty reassuring sign to us. And then also signs of preterm labor. One of the best ways that we've avoided preterm births is doing education on some of the subtle signs of preterm labor, because they can be very subtle. Sometimes it's just a feeling of light contractions. You're not really sure what's going on. Your abdomen's just tightening. Sometimes it can feel like menstrual cramps. Sometimes it can be a constant or irregular low backache. So all they're feeling is a low backache that comes and goes. Sometimes it's a feel of pelvic pressure, like I feel fullness, or sometimes it's even something very subtle like change in vaginal discharge. So again, we want to make sure that they report these things. And just quickly, a couple more things. Barriers to prenatal care. A woman's access to prenatal care, unfortunately, in the United States can be limited by financial barriers or systematic barriers, or sometimes even attitudinal barriers. Some of the financial barriers, that can be one of the most important factors in limiting prenatal care. Some people who do have access to Medicaid may not know how to access it or how to get it. Many women have no insurance or not enough insurance to cover maternity care, and they don't know about Medicaid. So So Medicaid does finance prenatal care for women, but the process is very lengthy and it's burdensome. And again, some women may not know how to access it or how they qualify. We have systemic barriers. Some women have a lack of transportation, which makes it hard to get to their prenatal appointments. Prenatal appointments tend to be very limited. So sometimes women have to wait weeks to schedule their first prenatal appointment. Sometimes there are scheduling difficulties. So prenatal appointments are usually scheduled during the daytime hours, and that can interfere with employment or childcare. And at the same time, sometimes you can make an appointment, but the provider ended up with somebody in labor in the hospital and had to go deliver a baby. And sometimes that can interfere with having, again, getting back to work and so forth. And there's even a sadly attitudinal barriers. And this is one of my biggest pet peeves. I mean, sometimes you just have these unsympathetic attitudes from healthcare workers towards those people who can't pay. And it seems horrible to say, but sometimes it can happen. And so that can make people feel judged and not want to come into the hospital because they didn't get prenatal care or they got prenatal late, which is never okay. Sometimes women might perceive the staff as rude or arrogant or judgmental. So again, women might even wait for appointments for hours and might never see a healthcare provider during that time because they're at a delivery. Or you might choose a healthcare provider, but they're part of a large group, and you might not see the same healthcare provider again because of the group. And some women, they do have a show that's called I Didn't Know I Was Pregnant. So some women truly didn't even know they were pregnant. So they show up with abdominal pain and end up having a baby on the toilet in the ER. So that does happen too. It's also important to be aware of cultural influences on childbearing. So it's important we understand people's health beliefs. Again, Western ways is not always the best way. So it's important for us to know health maintenance during pregnancy, any health beliefs in fate. So look, for some people, they think, well, it's fate. If the baby's supposed to be okay, the baby will be okay. If not, it won't. There's different cultural beliefs on preventing illnesses and restoring health. There's different modesty issues. Certain cultures may not want a man or male physician. Some cultures want to be covered during pregnancy. You have some that. Sometimes we even have women that come from other countries that have had female circumcision done. And so that's something to also be aware of. Communication techniques, making sure, addressing any language barriers, communication style, decision making. Some cultures don't want eye contact. That can be rude. Some people don't want to be touched. So it's about knowing all the different cultural influences on childbearing. And the best way you can know this is ask your patient. Okay, no one's ever going to be offended to know that you want to give them the best care that's appropriate to their cultural beliefs. We might want them to also consider the setting for birth. Some people choose to have home births. Some people choose to deliver in birthing centers. Some people choose to deliver in hospitals. Some people choose to have a midwife. Some people choose to have a physician. Maybe they want a support person. It doesn't necessarily have to be the woman's partner. It could be a friend. It could be a family member. They might hire a doula. A doula is a non-medical person who is trained in labor support. They're wonderful. So maybe they choose that. What are their birth plan considerations? Some people write up birth plans and it's their preferences for birth. Do they want intermittent fetal monitoring or continuous? Would they rather IV fluids or just a saline lock versus no IV? What kind of positions they want to be in for labor and positions for delivery, whether or not they want to use hydrotherapy, what are their plans for pain management, what are their preferences for medical interventions. How do they want to be with the baby? How long can they stay in the hospital? So all of these kind of questions are in a lot of women write in birth plans. Now it's important to do a flexible birth plan because we do have women sometimes that say, I don't want a C-section, I don't want this. And sometimes we just have no control over that. Obviously we want a healthy mom and a healthy baby. There's different types of prenatal classes women can go to. There's preconception classes, so that really teach about how to be in the best shape for pregnancy, early pregnancy, where they talk about maybe some of those discomforts and how to deal with them. There's certain exercise classes for pregnant women. Almost everybody gets childbirth preparation. So again, that's the key to laboring, is to kind of know what to expect. Maybe they know they're getting a cesarean, so they might do cesarean birth preparation. Maybe they want to breastfeed and take breastfeeding classes. There's parenting classes. There are even classes specifically for fathers that are called Boot Camp for Dads, is just one example, and also postpartum classes as well. And whew, that was a long one. This is probably the longest lecture you'll ever have, but we are done. Thank you for hanging in there. Again, you do have some mini lectures to watch, and they're much, much shorter, but it just kind of fills in some of the information we couldn't cover. Please be sure to use some of those practice activities, watch those videos, and again, don't hesitate to reach out to me if you have any questions at any time. So I hope your first week goes well. Next week, we're going to talk about giving birth, or what we call the intrapartum period. We're going to talk about delivery. Next week, you will also have your first quiz. It will cover modules 1, this module, and module 2. These are timed quizzes. It's 20 questions. You have 30 minutes to complete them in. It's going to open Monday of the week that it's due, but it opens Monday, but it's not due to the following Sunday by midnight, and those are all marked on your schedule. So I advise you to do your module 2 class before you do your quiz, but it is there for you. So I won't keep you much longer. It's 3 o'clock. Again, just reach out to me if you have any questions. You guys are a great group. Thanks for listening. Thanks for coming. And again, I recorded these, post them online. Thanks, everyone.